series using telementoring to optimize quality of care and quality of life for patients with metastatic kidney cancer. We refer to it as TOQQ RCC. My name's Katie Knight, and I'm a member of the research staff at the University of Kansas Cancer Center within the Division of Medical Oncology. And I've been fortunate enough to get to work on this project ECHO with Drs. Elizabeth Wolfe-Birchfield and Jennifer Klemp. And speaking of Dr. Wolfe-Birchfield, for those of you who've not met her, she is an assistant professor and medical oncologist with the University of Kansas Medical Center. And her specialties are genitourinary oncology and hospice and palliative medicine. Jennifer Klemp is a professor with the University of Kansas Medical Center as well, and her clinical interests are all things cancer survivorship and cancer risk and genetic counseling and testing. Jen's research interests have a lot to do with those same topics, but she's also interested in improving access to point of care service through telementoring. So it's really great to be here with you guys today. And Libby, I would like for you to not only say hi, but also introduce our guest speaker, Dr. Eugene Lee.
Greetings. Thanks to everybody. We're so lucky to have joining us today Dr. Eugene Lee, a colleague of mine who I'm lucky to practice alongside every day. So he's an associate professor of urology here and is a practicing urologic oncologist and the director of urologic oncology here at the University of Kansas. And he has, certainly has a broad and varied practice, but within the urologic oncology realm, treating quite a bit of renal cell carcinoma, also performing radical cystectomy for bladder cancer, and then certainly other things arise. So we're so fortunate to have him with us today to help us kind of, just work through the new challenges and deciding how to care for these folks up front if they have metastatic disease.
It's good to be here. Thank you.
Muted. All right. Okay, so here's a quick review of our agenda for today. If you haven't already, please sign in the chat bar for the session by putting your name and affiliated organization in the chat box. As always, our goal is to start and end on time, so I'll move through these next slides quickly. However, after each session, the slides, the recording of the didactic, and the tools referenced in the session will all be emailed to you probably early next week. I don't know why that wants to do that. Okay, we're going to take a quick pause. I believe we have one person that's with us currently. Let's see, Andrea. Oh, and Dr. Sinclair. Looks like we've got Amy and Trish as well. I'm sure more people will be joining, but as of right now, we would like for you to introduce yourselves quickly. And I'll just start up at the top of my screen with Tracy. Tracy, you want to say hi real quick?
Hi, everyone. I'm Tracy McCarty, and I am part of the Cancer ECHO team with Katie.
All right. And let's see, Dr. Sinclair.
Christian Sinclair, palliative care doc at KU, doing outpatient palliative care and work with Dr. Wolfe-Birchfield.
Awesome. Hi, Trish. How are you?
Hi, guys. I'm good. I'm Trish Long, and I'm from the Masonic Cancer Alliance, and I'm on the ECHO team also.
Let's see, Andrea, it's nice to see you.
I'm Andrea Sandusky-Uri, and I manage the Oncology and Infusion Center in Maryville, Missouri at Mosaic Medical Center.
I'm so glad you could join us. I was hoping you would. It's good.
Yeah, happy to be here.
And there's an Amy on the call. Amy, are you able to introduce yourself? If not, you can always do it in the chat box. Okay, well, we're really happy you guys are all here today. We've got a great presentation for you, so let's get started. Okay, so here is our conflict of interest disclosure for your review. The next couple of slides will give you some information on how to get those important continuing education credits. And for those of you who are not interested in getting CEs and would prefer a certificate of attendance, that is also available. The activity code that you'll need is 83 COL, and the deadline to enter that code is Thursday, May 20th by 5 p.m. You can do it this one of three ways. You can either enter it into that phone number, you can use eads.com from your computer, or you can always download the app and enter it in that way. This project is funded by a Pfizer independent grant for learning and change. And of course, this project wouldn't be possible without the additional support from the University of Kansas Cancer Center and of course, the Masonic Cancer Alliance. Just a reminder, we do record these sessions, and by participating, you are consenting to be recorded. Here are just a few Zoom tips for you, although at this point we are all experts and probably a little tired of Zoom. But anyway, we're gonna push through. Just remember, if you can, please keep yourself muted. Test your audio beforehand, speak clearly, use the chat box to engage. We're always monitoring that. Keep your cameras on if you have it, and hopefully you'll point that camera towards your face. Today, we also do, we like to do poll questions during these echoes, and the goal is that it just enhance your experience and our engagement. The prompts that will pop up, it'll just walk you through it. You just choose your answer, and then the best part is we get to see the results in real time. Here's today's learning objective. We really hope that you'll walk away with an additional understanding of the role of cytoreductive nephrectomy as it plays a part of the comprehensive renal cell carcinoma management. And finally, we aim to protect patient privacy, so please remember to only discuss patient information without any patient identifiers. All right, that wraps up our introductory slides, and now I will pass the torch on to Dr. Wolf Birchfield.
Thanks, Kate. So before talking a little bit about some of this data that has enriched our understanding, but also added us some complexity, I just want to talk about something that is a little bit near and dear to my heart, which is the difference between a cytoreductive nephrectomy and a palliative nephrectomy. And so, when we talk about cytoreductive nephrectomy, we're talking about this being undertaken for disease control and longevity versus palliative nephrectomy, which, theoretically could do that as well, but is really being undertaken because it needs to alleviate suffering. So it could mean uncontrolled bleeding, it could mean, flank pain, or it could mean, even significant iron deficiency anemia due to bleeding from the kidney mass. So I just want us to all keep those in mind because we talk about things in different scenarios. And so generally speaking, if someone needs a palliative nephrectomy, then they're medically stable to do that. But if they need it for the sake of their quality of life and overall well-being and dignity, then that is going to be always a different story than with cytoreductive nephrectomy, where there's more nuance. So if they need a palliative nephrectomy, then generally we think that's pretty acceptable. So as I said, that's kind of what I just covered a little bit, the idea that, if they are having physical and existential suffering related to their kidney primary because of pain, bleeding, and those sorts of things, then absolutely we would consider palliative nephrectomy in kind of a different class, even if it's not a circumstance in which we would do a cytoreductive nephrectomy in order to control their cancer and help them live longer necessarily, then palliative nephrectomy is okay. Sometimes folks can do kind of an embolization of their kidney and their kidney mass with it if they aren't healthy enough to do their systemic, or to stop their systemic treatment to do it, or if they aren't well enough to have an operation. And we may have, depending on time, we may be able to talk about this a little bit kind of ad lib later. But post-embolization syndrome is usually relatively short-limited with folks who kind of have, definitely a flu-like illness, so they can have fevers, rigors, nausea, body ache. So, it can last a couple of days, but that is still an option, and many interventional radiology folks still are able to perform that if that's deemed necessary for palliation. It's something to keep in mind. So since we are fortunate enough to have the good Dr. Lee here with us today, since he's a urologic oncologist, I wanted to hand this back over to him to talk some about cytoreductive nephrectomy and to share some data, and so that we can all also learn, since many of us are kind of medical in our oncology practice, we want his urologic oncology perspective. So take it away.
Well, thank you. So I think, obviously this, the bottom line is that it takes a really good discussion and good teamwork. And I think that Libby and I, we can speak from experience that most of these patients that present with metastatic renal cell carcinoma, the first thing that we do is we touch base with each other. We have clinic in the same space. And so we either walk over and talk to, each other about the patients that we're about to see, so that we can come up with an agreement on what we think is the best laid plans. And so I think that I would say is probably the number one thing, is a discussion between the team and with the patient, and talking through goals. And so I'll lead with that. When I was a resident, which now is, I think, like 15 years ago, and yes, I do have some gray hairs now. I am 40. I am getting older. But it was just as soon as somebody walked in the door with metastatic renal cell carcinoma, I mean, it was a straightforward answer that you are doing a cytoreductive nephrectomy. This is based on these retrospective studies from the 80s and 90s with interferon during the cytokine era. And the two particular studies that we always reference were the ones that showed about a 6-month survival benefit with a cytoreductive nephrectomy, keeping in mind that it really was the folks who had lung-only disease that probably did the best in those particular studies as well too. And by kind of just assuming from that, probably those who had pretty good performance status, et cetera. So subsequent data in the targeted therapy era indicates favorable overall survival with upfront cytoreductive nephrectomy. Those are not randomized trials though. And so much of this data is retrospective, saying that, taking the kidney out is going to be of benefit. I think the issue, obviously, with any of these retrospective studies is that there is an intense selection bias. Those folks who are going on to radical nephrectomy, I know it, Libby knows it. When we kind of select for these patients, they are the younger, more robust patients that have good performance status. And so no matter how you try to control for that in a retrospective study, you're just not going to be able to control for that. So obviously, we were ripe for these Carmina and Surtime studies, looking at a randomized trial of assessing whether or not the upfront cytoreductive nephrectomy is of value in a targeted therapy environment. I think it may have been Dr. Wolf Birchfield who said, when the primary author of this study was presenting this data, it was a French gentleman who is a urologist, and he kind of mentioned how he had kind of kicked himself by these data, because I think for most of us surgeons, we want to know that we're doing something of benefit. And I think if you ask any surgeon, what's the best therapy for a cancer, it's cutting it out. And so with that in mind, they ran this study. It was a randomized phase 3 trial, about 450 patients with metastatic RCC. And keep in mind, they were intermediate and poor risk patients according to IMDC. And they looked at upfront cytoreductive nephrectomy followed by sunitinib versus sunitinib alone, and looked at the primary endpoint of overall survival. It was a non-inferiority design. And what they found was that sunitinib alone was non-inferior to surgery plus sunitinib. And so obviously that was somewhat of a, maybe a surprise, maybe not. But that in reality, the overall survival in the sunitinib alone group was perhaps a little bit longer. Follow-up analysis indicates that maybe upfront cytoreductive nephrectomy may be beneficial for patients with only one risk factor. And I think the reality is that this actually does kind of go along with a lot of the retrospective data that we've seen. And really, it's that patients who have good prognostic factors, so lung-only disease, less sites of metastasis, better performance status, not having neurologic metastases, so brain mets, those patients tend to do better. And so this may be what this study is going for. I can get the next slide. The CERTIME trial was unfortunately closed prematurely due to low accrual. But what it was looking at was upfront cytoreductive nephrectomy followed by sunitinib versus 3 cycles of sunitinib followed by cytoreductive nephrectomy. So kind of a delayed nephrectomy. And so if there was no progression of disease, then you would go on to cytoreductive nephrectomy. The primary endpoint was progression-free survival. And really the rate was identical between the two groups. The survival, though, in the upfront nephrectomy was much less than in the delayed nephrectomy arm. 14 patients in the delayed nephrectomy arm had progression during initial sunitinib and did not undergo nephrectomy. So that's something to keep in mind when we kind of talk about what we have started doing now. And I think this is where I turn it back over to you.
Yeah, so absolutely. I mean, thank you for presenting all of that. And it's so important. And you know, when Dr. Mejan presented the data at the American Society of Clinical Oncology annual meeting in 2018, I had clinic the following day when Dr. Lee and I were going to be, or, you know, the following Monday or something, we were going to be talking about upfront cytoreductive nephrectomy for a patient. But, you know, he did, Dr. Mejan did put a little graphic that literally showed like a cowboy shooting himself in the foot. He was like, hey guys, I realize this is what I've done, but here's the data. It was funny. But even with this randomized controlled data, which is so meaningful, the decision-making still isn't clear because for most folks, as we had talked about in our prior echo, we don't really use TKI monotherapy any longer. And if we did, it certainly really would not be with sunitinib anymore. So while this is really important data, it still is outdated, unfortunately, because our systemic therapies have moved on. And we know that with the immune modulation that we're seeing in basically, unless someone has an autoimmune disease, essentially all folks are going to get an upfront checkpoint inhibitor. You know, the immune modulation is probably the part that has the greatest potential to interact in a synergistic way with cytoreductive nephrectomy. So that's why it still is, you know, important, but not the whole picture. Also, you know, the Carmina studies showed that there was a high proportion of patients who had poor risk disease. And I think any of us who've interacted with those folks just know that they're kind of in a league of their own. You know, they just can be very ill. And so it does bias things a little bit. It's tricky to know. So there are several ongoing trials that help to bridge, that are going to help answer some of these questions. Although, again, it's just so hard to keep up with the pharmaceutical trials that are happening right now. Although in truth, I think that the upfront systemic therapies we're going to be seeing a little bit less variety while we're still waiting for the remaining couple of big frontline trials to settle out. But so there are several that are going on right now. So there's a European trial called Nordic Sun, which uses nivolumab and ipilimumab, and then folks either get randomized to delayed nephrectomy followed by maintenance nivolumab or nivolumab maintenance. And then there is another trial called CytoShrink, which is different but related, which is essentially folks who keep their intact kidney mass, but either have nivo-ipi or nivo-ipi and radiation to their primary mass, which is part of trying to sort of create the abscopal effect. And, you know, I don't know about all of you, but I kind of think of the abscopal effect as this sort of distant immune-related response if we radiate or kind of usually radiate the primary mass. So, and then PROBE. So this is a trial being run through the SWOG Cancer Research Network, and PROBE is looking at upfront immunotherapy. There are multiple regimens available kind of as the field has changed for folks who, and then if they have partial response or stable disease, then they get randomized to either systemic therapy alone or nephrectomy at that point. So I think if folks have a complete response, then they don't have any surgery, and that's not offered to them, I believe. And then if they have progression of disease, then they would change to another systemic therapy line. But I think there's a lot more to come. Most of these have barely started enrolling, so it's going to be years before we really get a signal to guide us. So in the meantime, there's absolutely no substitute for open communication. I think that takes us to a poll question. Okay, so this may not apply to everybody, but I would be curious to know if folks on this meeting today have seen a drop in the proportions of patients over the last few years who are getting cytoreductive nephrectomies if they have metastatic kidney cancer. We need some poll question music, Katie, I feel.
I'll work on that. I feel like you're the music expert. You could probably help me write a little something.
A little ditty, okay.
Hey, aren't you a singer, Libby?
Yes, that's true. That is true. But I think some instrumental music would probably be more appropriate than me just like putting on a karaoke track and serenading all of you during this time. Okay. Well, it does look like from the polling that I think we can I think we've given folks enough time. It does look like there has been a drop, and I think Dr. Lee and I would echo this and just say that we do think that in our practice has changed. It's not that no one gets cytoreductive nephrectomy. It's just that honestly, when I was in training, when I was in my oncology fellowship, the genitourinary medical oncologist at the institution where I trained said, unless someone's actively dying, they get their kidney out. So, I mean, the philosophy has changed. So I'm not surprised to see that echoed, but thanks for answering that. Okay, let's see. So, here, I'm gonna close out on my page. So back to Ms. M here. So, my perspective right now is that if a patient is going to meet with a urologist, or even if, when I'm first establishing with a patient who has, de novo metastatic kidney cancer, that is part of my initial visit. And it's not as simple, yes, you need your kidney out, or no, you don't. For me, it's really that, our goal is to try and help educate the patient about what the role could be and when we would consider doing that for each individual person, especially knowing that some of these folks are going to need a palliative nephrectomy. So even if we're trying to do a delayed nephrectomy, then some of them may end up needing it sooner than we plan due to pain or bleeding. So what I would say is that because this person only has one IMDC risk factor, then I certainly think that a meeting with a urologist or urologic oncologist is appropriate. So the questions that she might ask would be, okay, well, when would we do this? And would that, is this is this a zero-sum game that if I do the systemic treatment, then I can never have the kidney out? Or, what does that look like? So, those are kind of another set of questions that commonly arise during these conversations, at least in my clinical practice.
So Libby, could I ask a question? And this is because I don't work in this space. Would this patient, and Dr. Lee as well, would this patient potentially be in a community urology clinic, or would they automatically get referred to, a specialty center? Because it seems like there's a lot of decisions here, and where is this patient residing?
Mm-hmm. Well, I would guess that, I think that patients do, I don't know, Dr. Lee, but my sense is that I do think patients see community urologists a fair bit. What would you say?
I would say that the vast majority of these patients will see a community urologist, but then eventually get referred to us for the actual surgical management. Partly because of the expertise of medical oncology, part of it from the operative standpoint, it does tend to be more difficult. They are larger masses, sometimes with obviously cable thrombuses. So that typically is sent to the university.
And then would you, as that patient, like let's say the patient comes from 2 hours away, would you then work with their local urologist to help manage any day-to-day things? Or do you have to kind of telemedicine wise manage that patient?
I would say that for the most part, if the decision is made to proceed with surgery, then once we do our first visit, oftentimes they're already booked for surgery after that. And then there's really not a lot of day-to-day management, I would say. But I would say that I would defer to Dr. Wolf Birchfield in terms of kind of the systemic therapy decision-making, and then turning it over to community medical oncologists versus whether they come stay at KU?
Yeah, that's a really great question, Dr. Klemp. I think that what I have seen also is that at least I personally encourage, even if one of my patients is seeing Dr. Lee, if they live very far away, I do try to maintain myself and have them maintain a relationship with their local urologist, because if they end up having significant hematuria and or have clot retention, meaning they can't urinate because clots are blocking up their urethra or something, which can sometimes happen if people have lots of bleeding, we need to have someone who can get to them faster than they can get here. But my sense has been just that these for a lot of these larger kidney masses, that they're surgically complex enough that if they get here, they're going to stay here, at least on a consultative basis. So, but we do a lot of co-management, I think, quite a lot, actually.
Well, and I know a couple of the folks on the call today are from a variety of practices. So it's really helpful to hear, because each disease state seems to have a little different shared care model, but it's really nice to kind of see how that works. And with so many patients being seen, across the state, that's really helpful.
Mm-hmm. Absolutely. Well, thank you for that. I really appreciate it, because those hadn't occurred to me, and those are really important thoughts and questions. And certainly, honestly, anyone is welcome to interrupt at any time if anything comes up. So, but for now, I'll just press on at the moment and say that, if this very astute patient, this is M, asks about safety, can I ever have my kidney taken out if I start with medicines first? That's a very reasonable question, and it's something that thankfully we do have some data to answer. So with so in addition to the Carmina and SureTime trials looking at the medical benefit of cytoreductive nephrectomy in metastatic disease, there have been several studies. There are some retrospective and several prospective that have looked at safety of nephrectomy after people have started systemic treatment, both targeted therapies like tyrosine kinase inhibitors usually, and then immunotherapy. So several of these studies were actually done for a slightly different purpose. So there were studies done kind of, conducted around, I don't know, something like 2009 to 2013 or 2015 or something like that, that we're looking at whether we can downstage patients and allow them to have an unresectable kidney tumor and or unresectable amount of tumor thrombus, make it resectable. And so because tyrosine kinase inhibitors were in such widespread use starting in the earlier aughts, there were studies looking at this. So essentially what it shows is that folks can have some downstaging of their tumors to make them resectable. But the most we can really expect right now is somewhere around a 20, kind of a 1 in 3 to 1 in 4 patients would probably get a meaningful amount of downstaging from an upfront tyrosine kinase inhibitor alone. Now, what I will say is, from an ethical standpoint, if someone has unresectable disease, then that is ethically the same as having incurable or metastatic disease. So even if someone comes to Dr. Lee with a tumor that cannot be resected, then again, it would be appropriate for us to do a single agent tyrosine kinase inhibitor, like what these studies did explore, the ones I'm describing on this slide. However, it would also be appropriate for us to do even more aggressive medical management if we think it's necessary to try and make it resectable, knowing that if we can't take it out, it can't be cured. So that's just kind of something I like to always remind myself of, because I have a lot of security in knowing I'm practicing within the bounds of the data that we have. However, the ethical framework is what it is. So, but what I would say is that since 1 in 3 and 1 to 1 in 4 patients had kind of a significantly reduced tumor volume, and well, it looks like in some studies it was up to about between a third to half, but the tumor volume itself has gone down by about 25 to 35%. But there really was not any increase in the surgical risk of these folks who were undergoing cytoreductive nephrectomy or definitive nephrectomy after this. So I think we can say that it is safe, knowing that we would work with our oncology pharmacy colleagues to hold it at the appropriate time in order that they wouldn't, impede wound healing afterwards and that sort of thing. But I think this patient can be reassured that from the tyrosine kinase inhibitor standpoint, it is safe. And then on the next couple of slides, we have some additional data about other things. So I'll start out and then I'll kind of throw to Dr. Lee to hear his experiences too. But there have been a couple of series that do indicate that conflicting information about the impact of checkpoint inhibitor treatment on cytoreductive nephrectomy for folks who have metastatic disease. And so, I have been a part of another conference where this was discussed, and it was pretty heated actually, because some folks really sort of believe it, and some folks have the perspective that, well, maybe you're just not as competent as surgeons. I really think the reality is somewhere between them. But it's interesting. So, the data seems to indicate that, and this is very preliminary. And as I outlined, we have some forthcoming studies that'll give us even more information about safety and with after checkpoint inhibitors. But one series, which was a French series with, experienced urologic oncologists at high volume centers, did see that there was that they had a more profound desmoplastic reaction, and just that those kidneys got really scarred down, and that operative time and hospital stay and blood loss seemed to be worse. However, there was an American series that didn't seem to indicate that. The main difference between those series when I have looked at them is that one had a much longer kind of median duration of their checkpoint inhibitor therapy, which was up to 40 weeks in the French series versus in the American series, it was often something like 3 months or less, I think in all cases, or in almost all cases. So I think it does seem that maybe checkpoint inhibitor treatment or kind of exposure time seems to have some impact there. And then we can, and I think there was one more slide there. Okay, so in any case, I mean, certainly having the conversation is always key between us. But so, Dr. Lee, what is kind of the urologic oncology perspective on this? Have you had any experience with this either way?
Yeah, so I guess what I'd like to do is just kind of start backwards a little bit and kind of discuss what renal cell carcinomas typically do and look like intraoperatively. So the standard kind of T1, T2 renal cell carcinoma, I always, equate it to a tumor that pushes normal tissue away. So, for instance, when we're doing a partial nephrectomy for a T1 tumor, oftentimes it's a very well encapsulated tumor that you can actually enucleate, meaning that you can almost kind of dig it out and shell it out. And it doesn't have like the finger-like projections of some types of tumors. So in general, when you're doing a nephrectomy, oftentimes those tissue planes are completely intact. There's not a lot of scarring or desmoplasia, which I try to equate, when I'm explaining that to patients, what desmoplasia and inflammation around a kidney is like if you just took some organs and then you just kind of poured glue all over it, and picking through all of that glue and trying to find those natural tissue planes. That's what the difficulty is when people describe this. So I think that, there's always going to be controversy in most surgical series. And I think it's, maybe I'm a pessimist, but when you go to a surgical urologic oncology conference, it's amazing how great people can do surgery. It's most of the time it's people talking about their own surgical series and look at me, I'm so great. I can do this left-handed. I can do it right-handed. I can operate with my feet. And so it's hard, I think that people have different approaches when kind of portraying their results. I think, from my own experience, I would say that people who have been treated with TKIs are a little bit different than the checkpoint inhibitors. I do think that there's a little bit more desmoplasia from the checkpoint inhibitors. Is it enough to kind of prevent us from proceeding on with surgery? No, I've never had to back out from surgery because of the desmoplastic reaction. The other thing to keep in mind, though, in one of the studies, and I can't remember off the top of my head, mentioned that they had to change the surgical approach. And really what that means is that they probably started laparoscopically or robotically, and they just weren't progressing, or they weren't, or they got into bleeding, and they ended up having to open in order to complete the operation. I will tell you, in my hands, I have a very low threshold to book somebody for an open operation. I think that in terms of these types of operations, when you're really worried about desmoplasia, I think it helps to have your hands actually in there, feeling the tissue, knowing exactly where the major vessels are, whether it's the aorta on the left side or the vena cava on the right side. And so I have a pretty low threshold for doing these open in general. And I think that from a recovery standpoint, I don't think it really changes outcomes that much. So I guess the short of it is that yes, I think it creates a situation where it becomes more difficult. I equate it to, for those of you who treat testicular cancer, so folks who have post-chemotherapy retroperitoneal lymph node dissections, that type of desmoplasia is very similar to post-treatment in this setting.
So but if folks do get converted from a laparoscopic nephrectomy to an open one, how much more time would they have to stay away from systemic therapy? Is it a lot more? To heal up well, I mean.
Yeah, it's always a really good question. I don't really have a strong feeling. I think, even with laparoscopy, you're still making an incision to extract the specimen. And I just don't feel like just because you have somewhat longer of an incision, you still have an incision. So I wouldn't, I don't really ever feel that strongly about holding or delaying therapy for that much longer, no.
Mm-hmm. That's good to know. I mean, it sounds like your summary is that it could be more challenging, and there could be a higher likelihood that someone would be converted from laparoscopic to open surgery. However, knowing that it sounds like it's not a huge barrier in terms of safety and of medical appropriateness. And so if it will help render someone, disease free, or will help consolidate them if they've had a good response to immunotherapy, or if they, if we think that they have minimal disease burden and it's appropriate, you have seemingly a pretty low threshold for that.
And I would tell you that I typically will not go into an operation thinking that I'm going to convert. So I would just approach it right off the bat with an open operation. Mm-hmm. And especially in these types of situations where you're debulking, especially if there's, retroperitoneal lymph node disease that you're wanting to resect, I think the ability to do a good retroperitoneal lymph node dissection robotically or laparoscopically is the quality is just not the same. So I do think that the makes more sense from the get-go. Sure. But I think when the papers show, there was difficulty and we had to change our operative approach, my guess is that they tried to do it robotically or minimally invasive somehow, and then they ended up converting.
Sure. We did get a question in the chat box about kind of immune-mediated myocarditis, or I think, even a broader, that's a really important question about cardiotoxicity if we're thinking that someone may have an operation. I think, there are other kind of immune toxicities that probably could increase operative risk theoretically. My understanding of the data with immune-mediated myocarditis is that it typically happens earlier. And we haven't encountered this in our group, although certainly, that could, I think that, with Dr. Lee and I, if we had a patient who'd had immune-mediated carditis, we would be in very close consultation with their cardiologist to determine, to help us weigh into the kind of risk stratification for that individual. It would depend on the extent of their response to their kind of their immunomodulation after their treating their myocarditis and things like that. I don't know. I mean, I will admit, I don't think that we have any data in the renal cell carcinoma literature to answer the question about folks who've had preoperative checkpoint inhibitor therapy. Are those individuals at greater risk to tolerate the surgery from a cardiovascular standpoint due to possible subclinical myocarditis? I don't know. I think that's a really beautiful question, and maybe even is something that should be done as a correlative study in some of these, in some of the forthcoming trials, right? Maybe, I don't know, actually would love to look at some of those and see if they're looking at any measures, troponin even, BNP, you know?
It's hard too, because TKIs obviously do have some established cardiotoxicity, but maybe kind of a little bit down the road. But I think the hard part is because what you're explaining in the description, which is lovely. Like, I've just learned a lot about, I love the sticky description you just gave, Dr. Lee. But I think, you know, when you think about how these are older patients, maybe, you know, comorbid patients, plus now you're layering on kind of these different therapies, and we really don't have great, you know, standardized ways that across oncology and surgery that we're consistently collecting kind of that cardiovascular risk. I just wondered, you know, how that plays out. But I like your description, Libby, about how, you know, it could be a question we ask, but I don't know if anyone does it great. But I just wondered how you did it in GU. So thanks for sharing.
Mm-hmm. Yeah, it's really important. Gosh, I think we are just tinkering with the immune system in a lot of ways that are helping people, but in ways that probably are going to have some unforeseen impacts that we're continuing to discover down the road, just like that, you know, the series about, you know, the French series that was where folks are needing to change operative approach and that kind of thing. But, well, thank you. That was really helpful. And I have used that glue analogy with folks after hearing him say it, and people really get it. It's because, you know, there is no one of women born in the United States who hasn't played with Elmer's glue at some point in their life. So we have all experienced it and know exactly what a mess it can be. But what I would say is just, we are going to have more data to help us answer this question. And I think right now, even though there are gaps, you know, and really right now, no data can really substitute for a good interdisciplinary discussion. We're going to have more information about predictive biomarkers of response and predictive biomarkers of overall survival one day, hopefully. And so we'll be able to know a little bit more, but we can move on to the next slide. So, I think I'd love to hear, you know, based on your prior experiences and some of the data, we'd love to hear the extent to which people might be comfortable referring patients for a delayed or deferred cytoreductive nephrectomy, or, you know, if people have done this, then I guess I would assume that they were comfortable with it. So we can open up the poll questions, and if there's any, you know, if you have any personal criteria that you use to rationalize this decision making, then please throw it in the chat box. We can all learn from each other.
I gave you some music, Libby.
Oh, thank you. I love it. Well, thank you. It seems like on our end that there is some, you know, that there is some comfort there in this idea of delayed or deferred nephrectomy, even though those trials are going on. And, you know, I do find Dr. Lee's experience very compelling and seems to be similar to that which we hear at conferences and from colleagues at other institutions. I think initially there was this narrative that like never take someone to the OR after they've had immune checkpoint inhibitor therapy. And then there's been so much reassuring data and experiences that have come after that have meant that there's no need to have absolutes in this area. We really can just take it on a case by case basis.
Hey, Libby, I have a quick question.
Regarding
delayed or deferred nephrectomy, you know, I know in breast cancer, my experience has predominantly been in breast cancer. And a lot of times patients have a really hard time hearing that they're not going to the OR first.
Mm.
You know, the whole,
Mhm.
they don't like the idea of it being delayed. I would imagine you run into that similar issue. How the communication part's always an important one, and that's been a big theme of your talk as well. How is it that how do you prepare a patient for that? How do you and Dr. Lee both, when you talk with them about this process, what does that look like for you?
Well, it's interesting. I'll start, but you know, we come at this from different directions because I think Dr. Lee's experience is that often folks are referred to him by other urologists who say, like, go see Dr. Lee and have your kidney out. That could be wrong, but I think that happens in other diseases that he treats, particularly bladder cancer. And that's a whole other challenge, because then not only does he have to, educate them about timing, but, he also oftentimes is introducing the new notion that they need systemic treatment, which is an even harder communication. If folks are coming to me first, then a lot of times, or if they've, usually if they're coming to me earlier, then what I tell them is that the focus is to make sure that they're getting treatment that we want them to only get helpful treatment and safe treatment. And so since we know that, their kidney mass itself is not likely to do them significant personal harm or to really threaten their life directly, at least not in the shorter term, but their metastatic disease, it could do that. They could become very symptomatic and ill or have pain or other symptoms due to their metastatic disease. And so in some ways, if they really need to upfront systemic treatment, then the discussion is about, we're trying to keep you safe and keep you from other suffering by controlling your metastatic disease first. And sometimes there are cases where it really could kind of be either way, and it's fine that that Dr. Lee and I kind of work it out amongst each other and then present a unified recommendation. But if it really is that they need systemic therapy first, and I think the focus needs to be on, not that we're taking away something from them that they think they need or that they would have a peace of mind to have, but to tell them, we're not necessarily taking that away forever, but that right now, this is about kind of keeping you safe, promoting your overall well-being, and preventing you from getting other symptoms from your metastatic disease, and so that we can preserve the opportunity to circle back and consider it once we know it's safe, and that you can have a break from your systemic treatment. So I think patients, often are, I think that does hit home with them, because most of us in our personal lives have known somebody who is very sick from cancer and have seen what that looks like. Most of us have some fear of that. So, but I'd love to throw it back to you, Eugene, because I know that at least with bladder cancer, which is a little different, a lot of times you're really having to change courses because of the communication that has preceded your visit. And so I wasn't sure if that was the same with this, or if it's what it's like on your end.
Yeah, so it's a very good question, because yes, it seems very unnatural to be a surgeon talking people out of surgery. So that's first and foremost. But what I explain to patients is that your outcomes, and I will reference the Carmina trial to them and kind of explain it in terms that they would understand. What I tell them is that because the disease has already left the kidney, the systemic therapies, the medications, that's really what is going to determine your ultimate outcomes, is how you respond to that systemic therapy. And so I tell them that if we're talking about what treatments do you need as soon as possible, it's really that systemic therapy. And my fear would be that at best case scenario, it's 4 to 6 weeks around the time of surgery that you can't get that therapy. And worst case scenario, I say, this is a difficult operation. If you have a complication, then that 4 to 6 weeks could turn into 3 months of not getting the therapy that you truly need. And so usually once we start talking through that, patients really understand what we're talking about and are completely fine with that. The one caveat to that I will say is that if somebody comes in severely symptomatic, and I know that we're not talking about that right now, but that is the one caveat to, oh my gosh, I'm in pain, or I'm having this recurrent bleeding. Those are the situations where, again, I'll have conversations with Dr. Wolf Birchfield, and we'll say, from a symptomatic standpoint, I think it's best to do this up front. So I just wanted to throw that in there.
No, that's great. Thank you, guys.
My other sense is, I often do think that patient's perspective is like, well, if my surgeon really doesn't think that we should operate, then that's probably sound advice. I agree. The palliative nephrectomy is a totally different story, because if patients need that, then they need it. This data does not apply to them, because if their overall comfort, dignity, or physical or existential suffering is such that we can't really manage it in an acceptable way with them keeping that kidney in there, then that decision kind of is made, assuming that they're healthy enough to have an operation. So it really is, it's kind of you know, and there are times when I've seen patients who, you know, like we're having a consultation with, you know, Dr. Lee and I on the same day, and I've said, texted him or sent a message like, FYI, your 11 a.m. patient needs their kidney out, or whatever it was, you know, obviously HIPAA compliant, of course, but, you know, or send a message through O2, or, you know, peek my head in to say, like, we can't, I won't be able to get this person through systemic treatment if they can't manage if we can't manage their pain and bleeding first. So sometimes the surgery actually facilitates the medical plan in reality. So
it sounds
well,
like
great.
it sounds like it's all about communication and that shared
Oh,
decision.
of course.
I
Isn't
mean,
everything?
end of the day,
Everything
right?
is.
Yeah.
Dr. Sinclair would agree. I'm not throwing him under the bus, but we're both palliative care physicians, so we think communication is actually everything. So in any case, so back to this patient, I think that this particular patient, you know, would be the great person for her to meet with this urologist or urologic oncologist, depending on his or her training. And then that person and I chatting about it and saying, okay, well, you know, this patient's, you know, let's say metastatic burden is such that we think that she would benefit from upfront systemic treatment. And then we would do that treatment for usually 3 months or so and restage, and then have a tentative plan to do what we would call consolidative surgery after that time, if she's had some response or at least stable disease. You know, a lot of what we're trying to avoid is that scenario that we did see with some of the patients on the trials, that they got so sick so quickly and their cancer progressed on their first line of treatment. Those patients they can't benefit from a surgery if their disease is that aggressive. So, but if we get their disease under control, then that can be a different story. So in any case, if we're thinking about, and I'm trying to remember, Katie, is that symbol, does that mean you want us to put it in the chat box at the bottom? I don't know. Anyway,
Yeah,
but I think
absolutely.
so if there are, you know, if anyone has thoughts about what criteria you might strategically kind of implement with your urology or urologic oncology colleagues to decide who you would be more likely to do delayed or deferred nephrectomy on versus considering it more upfront. For me personally, I do think folks who have low volume metastatic disease and folks who have, you know, truly oligometastatic disease, especially if we can render them kind of disease-free on imaging by doing a metastatectomy and having their kidney out, those are absolutely folks who we should be considering upfront. Certainly palliative nephrectomy is appropriate at any time, including upfront. And I would say, generally speaking, folks who have poor risk disease are folks who I'm going to be very unenthusiastic about doing this first, outside of the context of a clinical trial. I mean, there are still patients who may need that from a palliative standpoint, or, you know, for whom there are still going to be some poor risk patients out there, but the vast majority of poor risk patients, I think, really probably need systemic therapy up front. So I think we have another slide or two. Yeah, so I would say this is my own perspective. So I would say if people have oligometastatic disease, especially if they have lung metastases only, if the person can have metastatectomy or who can have, you know, radiotherapy to their lung metastases, you know, a couple of them, then absolutely, cytoreductive nephrectomy could maybe even help render them truly disease-free. I think the sometimes group for me is folks who have one risk factor for their that, you know, intermediate risk technically, but only have really one factor. And that's really kind of what the Carmina data shows. So those folks are minimally symptomatic, especially if they have lung metastases and or lymph node metastases only, because those are the folks who really do tend to have the best prognosis overall. And then I would say deferred nephrectomy for me often is going to be for some intermediate risk patients and for most poor risk patients, so that we can get them on their upfront systemic treatment. But as I said, remember, palliative nephrectomy is medically and ethically appropriate when needed. That could be upfront for a poor risk patient if that individual is really struggling. And as I said, it can actually facilitate the medical treatment plan in some cases so that they'll be more functional, have less blood loss, less anemia, less pain, all those things. So that's absolutely something that can be appropriate to consider. So I know that we are about to wrap up, so I'll hand it back over to Katie to lead us home.
Yeah, thank you guys. This was an excellent conversation about this topic, and I was wondering if there was anybody that had any questions for Dr. Lee or Doctors Lee or Wolf Birchfield. If you think of something, pop it into the chat. We've got a couple of minutes. Actually, we've got about 1 minute. So I have a couple of additional slides to review just real quick before we wrap up. I don't know why that doesn't want to work. Okay, so don't forget we have our next TOQQ RCC Echo on Friday, June 11th, again at noon. We will be discussing immunotherapy toxicity monitoring and management, including with regards to at-home immunotherapy administration, which is a hot topic right now. So I'm excited about seeing what Dr. Doolittle has to say about all of that. And finally, if you are interested in attaining those CEs, don't forget to enter that identification code 83COL by Thursday, May 20th. And just a reminder, all these slides and the toolbox items and those toolbox, the little toolbox on each of those slides indicates that's an article that's part of the toolbox. So we'll send all of that out to you to share with your colleagues and those that it might be of interest to them next week. And again, thank you so much, Dr. Lee, for joining us today. It was really nice to meet you. And we look forward to seeing you guys again on June 11th. Thanks, Dr. Wolf Birchfield.
Thank you all so much. I appreciate and I'm honored by your presence, and I hope you have a wonderful weekend.
Bye, everybody.
Thank you.
Bye-bye.
Thanks.